Thank you, Ms. Seema, for your help in organizing this recording. And thank you, Dr. Suhas Monde and your office bearers for giving me this opportunity to sensitize, the elite audience of nephrologists about how isotopes can help in small bit way in management of various cases. So between conventional radiology and nuclear medicine, the principal difference is, you all know, that radionuclides provide exquisite functional information with significant compromise in structural resolution, whereas conventional radiology, be it CT, ultrasound, MR, provides excellent structural information. Any indirect function information coming is purely complementary and coincidental. So in this small presentation, I'm going to cover up these topics, which will include the application in estimation of GFR, about how it helps in renal infections, how it, what are the limitations, fallacies, and etc. So the radio tracers which are available for evaluation of kidneys could be in general nuclear medicine or in positron emission tomography. You all know the difference. One uses gamma camera for imaging of various organ functions, whereas positron emission tomography molecules are short-lived. They provide cellular activity at the molecular level. So DTPA, diethylene triamine pentacetic acid, the standard, alternative to doing inulin-related GFR estimation, because inulin cannot be labeled with a radio tracer. This is the closest compound which can be. And Gary Gates, who devised the GFR estimation way back in 1980s, it still remains so reasonably dependable method. EC and MAC3 are both tubular dynamic agents that bypass the glomeruli. So in a patient who has elevated creatinine because of glomerulopathy, in such patients, if you want to document obstruction, then perhaps we should choose EC or MAC3 over DTPA, because both of these compounds, they bypass the glomeruli. DMSA, the gold standard for pyelonephritis and renal scars. Iodine labeled heparin we don't use because of high radiation burden, and MIBG, of course, for pheochromatography. Coming to the PET side, we have 2-deoxyglucose, the glucose analog, which is the workhorse for PET scan. Somatostatin receptor PET scan in those patients who have where you're suspecting neuroendocrine tumors. Prostate-specific membrane antigen is a molecule for evaluation of CA prostate, and we'll talk about FAPI. So here I already talked about estimation of GFR that bypasses the glomeruli. Heparin used to be used in past, we don't use it any longer. And that's static imaging. After administration, you wait for about 2.5 hours and acquire images. So it's not a dynamic scan, it's a static scan. I usually like to share this slide before any talk. Mokusatsu, 1 word and 2 lessons. This the Japanese general was given an ultimatum by the Americans before they dropped the atomic bomb that they should surrender unconditionally, and to which the Japanese said that use this term mokusatsu, but unfortunately it was not correctly translated. There are 2 meanings to this word. One is to just remain silent, that means to remain in masterly inactivity, and it also means to view this with silent content. So somebody did not translate it correctly, and this is what happened, mushroom clouds. And that's the New York Times headline saying, good translation might have prevented Hiroshima and Nagasaki. So that's what I always keep in mind, without having adequate clinical background of what we are dealing with. It is all gradient flight studies are prone to plenty of errors, and the limitations have to be understood on both the sides of the table. For instance, here is a patient who had been having ultrasound twice hydronephrosis, was sent for a renal scan. On the renal scan, you can see that the left kidney shows a functional contribution of 18%. But when you critically look at the dynamic images, the right kidney shows good uptake and excretion over a period of time in the bladder. But look at qualitatively, the left kidney hardly shows any uptake. So if you draw a region of interest anywhere in the body, it's going to show you some functional contribution. But a critical review of the ROI is necessary, and you have to redraw and then give what is more realistic functional contribution of hardly 8%, which was overestimated in this patient. Here is a patient who was referred to us for GFR evaluation in a prospective donor. And on the scan, you can see both the kidneys are showing good uptake and excretion, but there is a catch. Both the kidneys appear to be converging medially towards the lower pole, which is quite unusual. So we suspected that this could be a horseshoe kidney in a prospective donor, and further evaluation with a properly done ultrasound with bowel preparation will probably resolve this issue. So sometimes this isthmus can be very well appreciated, especially on a DMSA scan, but on a DDPA scan, you can only suspect based on the configuration of the kidney. That's a structural limitation that we have. Here is a young patient who had flank pain suggestive of ureteric colic with mild hydronephrosis ultrasound. You can see that the left kidney shows it's a little bit enlarged. It shows delayed extraction of tracer with progressive accumulation over a period of time. The right kidney shows good uptake, but sluggish excretion because the bladder doesn't fill up here. Sometimes in a dehydrated patient, this can happen. So over a period of time, you can see the left kidney shows progressive accumulation. This shows good uptake, but sort of indeterminate renal pattern. So in such patients, you acquire a delayed image. So in delayed image, post-void and delayed. There is progressive accumulation in the left kidney, which means it's obstructed. Right kidney, which shows some hold up here, drains out completely. So this is an unobstructed right side and an obstructed system on the left with a compromised function of hardly 20%. A procedure was performed, and this scan was, you can see, was done on 22nd of April, and post-procedure, this was on 21st of June. In about 2 months' time, you can see both the kidneys show, even the left kidney shows good uptake and excretion. The renogram pattern is virtually normal bilaterally, there's no retention. So what was the procedure which was done? The procedure was very simple. They did an RGP and BJ stenting. There was tiny calculus which was displaced, and what appeared to be a compromised, enlarged, functioning kidney with parenchymal compromise had regained its function completely after the procedure. So one important limitation is based on the renal scan, you cannot determine the cause of obstruction. It could be PUJ obstruction, it could be a calculus, it could be a DUJ, so it could be an aberrant vessel, etc., etc. So that's a structural limitation that we have. Is there a cutoff value at which kidney is to be considered salvageable? This is an important question repeatedly asked. If the percentage function is less than 10% or 15%, would you still want to conserve the kidney or would you sacrifice it? And the answer lies in, once again, understanding the limitation. In an acutely obstructed kidney, because of calculus, or an acute or chronic obstructed kidney, or in a pediatric age group with a large kidney, there is no cutoff value, which will tell you that below this, you will sacrifice the kidney. Because acutely obstructed system, the renal can underestimate function, and no matter what the functional contribution is, you have to relieve obstruction. The same is valid in children, except in an infected kidney. So just as it may underestimate function in an acutely obstructed or pediatric age group, when does renal scan overestimate function? So one important reason is pyonephrosis, where there is a lot of inflammatory tissue around the kidney. And as a physician, if you do not correlate with proper history, ultrasound, you may overestimate the function. Renal scan may overestimate the function. So here is one such patient who had left hydronephrosis. You can see there's hardly any tracer uptake in the dynamic imaging with a contribution of hardly 6%. Renogram pattern shows progressive accumulation. Delayed image shows retention. This patient had undergone stenting, and post-stenting, you can see that the quality of uptake in the left kidney has improved significantly. The renogram curve, I mean, the percentage function from 6% has jumped to 17%. And you can see a significant retention, much higher as compared to. So that's the pre-RGP and JJ, post-RGP and stent. You can see that initial 4 images, you may think that it's not much of difference, but later part of dynamic images between 27 and 30 minutes, what was so poor here has significantly improved. So there is significant improvement in function. So not only the quantification which is given by the curve is important, the qualitative images are to be given equal importance, and you can always question your nuclear medicine colleague as to whether the qualitative and quantitative parameters are matching. So what else is underestimate functional contributions? This was one important blunder which we had made. This patient was referred to us with a diagnosis of renal tumor on the left side, and we did a scan. The tumor was on the left side, and we said that the functional contribution is 18%. You see the right kidney is hardly showing any, it's showing delayed extraction. And we said 18% from renal contribution here, and the surgeon calls back saying that the patient is harboring tumor on the left side, and you are saying that the right kidney is compromised in function. I can't believe it. I said, I will review the case. And then he said that there is a large cyst on ultrasound, which is in the posterior cortex of the right kidney. So I said, that can definitely attenuate the photons and underestimate renal function. So please let me repeat the scan on another day. We repeated the scan in the anterior view. This is the posterior view, and that's the anterior. Look at the anterior view. Both the kidneys are almost equal in function in the anterior, because the photon attenuation because of the cyst was eliminated in the anterior view. And here you can see there was equal function. Initially, it was showing as 18% on the right side, but when the scan was required in the anterior view, the right kidney contribution was 48. This was published in one of the journals, limitation. What about false negative renal scan for obstruction? Now, this patient was referred to by a urologist saying the patient has typical ureteric colic, and we did a renal scan. He said it's a normal scan. But the urologist said, I can't believe this is a normal scan. The patient has very typical case. I said, PUJ could be a dynamic obstruction, and let us repeat the scan using what is called as an F-15 protocol, which involves administration of Lasix about 15 minutes prior to starting the scan, so as to challenge the kidney with higher volume or higher workload, higher volume of urine. That's what we did on another day, and look at that. This obstruction is now manifest on the dynamic scan as retention over a period of 30 minutes. And on the renogram curve also, the initial scan shows normal, whereas F-15 protocol shows obstructed left renogram pattern. So that's another important, utility of intervention in the intermittent obstruction can be because of dynamic obstruction, which, as I said, could be flow related. The second is calculus, which is mobile and can cause, and third, of course, is vascular. For instance, in this child who had ultrasound evidence of mild to moderate hydronephrosis, renal scan showed a percentage contribution of 35% on one side. It was followed up at another hospital. Again, the functional contribution was 35, 38. Both of them said that they are non-obstructed. The patient came to us even we repeated the scan and said, yes, it's 38% unobstructed kidney. You can see both the T half is less than 10 minutes unobstructed. On once again, the physician calls, urologist calls saying that the patient's symptoms are very, very suggestive. I said, let's repeat the scan during the symptomatic phase. So here the patient had, that's a follow-up ultrasound. The patient was referred to us again after some few months. This was in September, that was in February. And then, we repeated with F-15, nothing happened. And then we said, let's do during symptomatic phase. And the patient returned in April 23. You can see here the left kidney shows hydronephrotic obstructed pattern. There's progressive accumulation of pressure. So what happened between the previous asymptomatic phase and the symptomatic phase? The patient's obstruction was manifest, was proved or ruled in. And we thought that one of the important causes of intermittent obstruction could be vascular, and so he was explored, and there was indeed an aberrant vessel accounting for the Beatles crisis. So here is a patient with a middle-aged patient with hypertension who had CT evidence of renal artery stenosis, about 70 to 80%. So the patient was referred for a functional evaluation. You can see that the right kidney shows good uptake and extension. The left kidney is smallish. It shows suboptimal, about 27% contribution, and there is progressive accumulation in renal parenchymal accumulation. So that's moderate parenchymal compromise because of renal artery stenosis. And important causes of hypertension are renovascular, others renal parenchymal disease because of glomerular sclerosis, and of course, pheochromocytoma. And between these two studies, this one was done as baseline renal scan, and this one was after challenge with captopril. You can see that the left kidney refuses to show tracer uptake after captopril challenge because of the angiotensin converting enzyme inhibitor effect, which the angiotensin 2 is actually responsible for maintaining the perfusion of the kidney in the affected artery. And that's how the GFR is maintained, because the post-glomerular arterioles are they constrict under influence of angiotensin 2, the effect of which gets eliminated on administration of captopril. And so the GFR, the filtration pressure GFR falls down, and that becomes obvious on the renal scan. And this was, of course, the stenosis seen and effectively treated. And renal artery stenosis can present with malignant hypertension, unilateral small kidney, patients who have impairment of renal function or administration of ACE inhibitors, sudden worsening, etc., etc. So these are the situations where you can suspect, and these are the various patterns of renogram, depending upon the severity of abnormality that you come across. So unilateral small kidney could be because of the renal artery stenosis, it could be because of reflux nephropathy, or it could also be congenital. And to a very simple, objective, highly sensitive method to diagnose basilico-inhibitory reflux is radionuclide voiding cystourethrogram, which is performed without catheterizing the child. You can see here the isotope is being administered in the bladder suprapubically, with a tiny dose of 0.5 ml administered suprapubically, and the child is asked to void in front of the camera. You can see bilateral basilico-inhibitory reflux. VUR, as you all know, is intermittent, and sometimes one negative study does not necessarily rule it out, as seen in this patient. You can see here in one part of the dynamic study, it's showing reflux on the right side. In yet another part of the dynamic study is showing on the left side. So for this was bilateral basilico-inhibitory reflux, intermittently seen. Here's a patient who had young patient with renal transplantation and with creatinine which was a little higher, and an MCU post-transplantation there was ectopic kidney. That was a transplant kidney with suspected reflux. So we did a reflux scan, and you can see there's refluxing ureter here on the right side as well as left side. So probably the patient had a refluxing needle as well as the transplanted kidney. So direct renal scan was performed, which showed good function, reasonably preserved function with no obvious obstruction, price renogram downsloping curve. And they wanted to know now that the patient has refluxing transplant kidney, if there are any pyelonephritic scars. So a DMSA scan was performed, and you can see here multiple cortical-based cold areas suggestive of pyelonephritis/scars. Okay. Better seen on pinhole imaging. That's the difference in the collimator. You can see these scars are not so large, but on the pinhole collimator, this is a wonderful tool. You can, demonstrate the scars much better. So here is a 1-month-old child with history of posterior valve perforation and COI reflux. How does renal scan help us in deciding the management strategy? DMSA scan shows normal function, no scars when the child is 1.5 months of age. However, this child was followed up subsequently, and as the child was 2 years of age, the right kidney continues to show normal tubular function with no scars, but the left kidney has sustained infected pyelonephritic scars here. So, the pediatric surgeon can, at this stage, decide on intervention. So these are the two equipments, the gamma camera and the positron emission tomography, which is a fusion of two scans, the gamma camera, the PET gantry and the CT gantry, which is fused together. And for me, this is just scaled up version of a stethoscope. Just as you examine a patient and try to rule out, dissect between various causes of systolic murmur or bronchial breathing. Similarly, a hotspot seen on a PET scan or a cold area seen on a nuclear scan help us as an emergency physician to dissect or narrow down various differential types. Often asked question is there a PET equivalent of a diuretic renal scan? These are the diuretic isotopes, the DTPA, EC, MAC3. That's a static. So these are two equivalent of one of this and one of this. Deoxyfluorosorbitol has been tried experimentally, and this is if this becomes available, this is currently not available. If this becomes available, it has the potential of replacing DDP or ACE scan. Similarly, amino benzoic acid labeled with carbon 11, PABA, can replace DMSA. The problem is carbon 11 has a very short half-life and requires on-site cyclotron. So that's a limitation. This, of course, it can be transported at a distance of 5 hours, 4 hours. Long-standing hypertension in a woman who had pain in abdomen frequency with a blood sugar of 500. Now, you might have come across this practical situation in your own practice, where the physician calls you, nuclear medicine physician calls you saying that the patient's blood sugar is 300 and I cannot perform the scan. This patient had come to us from outstation, 3 hours of traveling, diabetes is uncontrolled, she had abdominal pain, frequency of micturition. What do you do? So try to overcome this logistical problem. Either you call the patient on the next day, the patient may not find it convenient or may refuse, or the sugar may not be under control even on the next day or next week for that matter. So we have a beautiful agent in the name of FAPI, fibroblast activation protein inhibitor. As you can see, there is no uptake in the brain, which is typically seen in FDG. There's nothing in the liver. There's nothing in the heart. FDG shows accumulation in these areas, whereas FAPI doesn't go anywhere else. You can see here there is intense uptake of FAPI in both the kidneys, and we suspected that there could be something wrong here. So we did a complementary MR. You can see here there are multiple areas of altered signal intensity suggesting edema. So we repeated a DMSA scan on another day, and you can see multiple pyelonephritic scars involving both the kidneys. This patient was put on antibiotics and responded well to the treatment. So the localization of this was published in Asia Oceania Journal of Nuclear Medicine. Gallium fatty, fibroblast activation protein inhibitor in diagnosis of certain tumors and first in occult infection. Here's a patient who had undergone transplant. The creatinine was borderline high. Patient had hydronephrosis, hydroureter on ultrasound. The perfusion, this is the single most important parameter we look at in renal transplantation to differentiate between rejection and acute tubular necrosis. Patients with fast or normal aorta to transplant transit time are likely to have unlikely to have rejection, unlikely to have ATN or drug toxicity rather than rejection. So perfusion images are quite normal. Good uptake of isotope over a period of time. And what about renogram? It shows progressive accumulation of tracer in the kidney, which means we're probably dealing with an obstructed kidney. So here, the renal pelvis is also showing fullness. The ureter is showing retention. We said this is likely to be obstructed transplant kidney. So the patient underwent anastomosis between the renal pelvis of the transplant and the native ureter. 2 weeks after this, the patient started developing fever, which did not respond to conventional treatment at all. So after a couple of weeks of fever, patient was sent to us for a FDG PET scan to look for occult focus of infection. So that these are calcium physiologic uptake in the kidney, in the native kidney. The contour is very well preserved. There's nothing in the cortex to suggest focus of infection. But look at the whole body scan. That's a transplant. There's a tiny dot over here. Can you see that? So once you trifurcate on that tiny dot in the region of native kidney, you can see focus of uptake in the renal cortex of native kidney. Now, what could this be? Focus of pyelonephritis involving the native kidney, the kidney which is dysfunctional. So why should this happen? And the answer lies in this intravenous CT scan. You can see here, that's the native kidney, which is not seen in the initial image. The transplant kidney shows excretion of contrast, and the delayed image shows tracer in the native kidney, which is because of reflux. So this was actually reflux from renal pelvis of native kidney to the transplant kidney to the native kidney, which was the reason for pyelonephritis. This was published in once again in the Asia Oceania Journal. And that's our Atlas article of FDG PET in PUO. Well, how does nuclear medicine help in macroscopic hematuria? Not proven in literature, but this was a practical situation we came across. A urologist friend said the patient has been bleeding, having hematuria. Can you do something? I said, it's a proven test for GI, but let's try it in the urogenetic system. And you can see here, there is a linear that's physiologic in the intravascular compartment. There's something here in the region of urinary bladder, which is progressively accumulating. So we said, do something over here. This is active bleeding in the urinary system, lower urinary tract. Patient underwent definitive procedure. There was bleeding at the medial, the VO junction, which was cauterized and correct. This child complained of headache following micturition, and they all thought that this is simply feigning at the time of exam. But the physician said, no, we'll do an ultrasound. An ultrasound showed something in the bladder wall. CT scan was done, which showed bladder wall thickening. With that, the patient came to us for MIBG scan. MIBG scan, as you know, has its own limitations. It's a very specific scan, but this was all urinary activity. We could not conclude, so we did an FDG PET scan. Those days we didn't have either DOTA or DOPA. So look at that, intense uptake corresponding to the thickening. We said this is likely to be extra-adrenal urinary bladder wall pheochromocytoma, and this was operated upon and proven to be pheochromocytoma. That's another highly specific agent, iodine labeled MIBG for pheochromocytoma. That's a tumor sample. And these are the isotope molecules which are used to diagnose pheochromocytoma. The specific ones are MIBG, carbon label ephedrine, and DOPA, and non-specific being DOTA, FDG, and octolite. This is one of our papers in This lady had come with a pathological fracture from an orthopedic surgeon saying that this is a metastatic pathological fracture. Look for upper primary on a FTG PET scan. We couldn't find anything except this pathological fracture and extensive osteolytic lesions here. So is this multiple myeloma? But we gave benefit of doubt and asked for calcium, PTH, and the PTH was 2,400. We did a systematic scan. There were two adenomas over here. You can see here, left superior adenoma in this tracheal superior groove, and another adenoma here. So there, and this was right inferior adenoma. This patient, as you know, hypercalcemia, the disease of renal stones, abdominal blues, mones, bones, and eyes. This patient who had difficulty in, walking around without help now is completely independent post-surgery. About not an infrequent request that we get is suspected renal insufficiency because of myeloma light or light chain, abnormality, plasma cell dyscrasias. These could be either light chain gammopathy, monoclonal gammopathy of undetermined significance, Mullering myeloma, which has potential of turning into multiple myeloma at the rate of 10% every 5 years, or frank multiple myeloma. So how does PET scan or nuclear medicine help in this situation? As per the literature, to suspect myeloma, you have to have at least 2 lesions on MRI of more than 5 millimeter, and a single lesion of 5 millimeter either on plain X-ray or low-dose CD or an FDG PET scan. So here is one such patient who had diabetes, renal insufficiency creatinine was that much. The free kappa light chain was high, free lambda light chain was high. Electrophoresis was negative for the M band, and they wanted to know if there is any evidence of myeloma on an FDG PET scan, any osteolytic lesions which could be targeted. So in absence of FDG avid osteolytic lesions, our protocol is we also have an MRI, which we offer as a complementary procedure whenever FDG sort of gives us we suspect that it could be false negative. So an MRI of spine is done in such cases to look for any marrow. So here is one such patient who had an osteoporotic collapse here, sclerosis over here, but otherwise no osteolytic FDG and just heterogeneous uptake on FDG scan. We did an MRI. There was a single lesion of 5 millimeter on MR in this. So this was not a conclusive scan for myeloma, because you need to have at least 2 demonstrable lesions on MRI to call it, gammopathy, light chain gammopathy, or early myeloma. Thank you very much for your kind attention, kind opportunity given. That's our clinic, dedicated nuclear medicine services center, and plants are our sort of main passion, and you can see over a period of time, these have grown substantially. Thank you.